I'm here to present my study on impact of knee osteoarthritis on balance, perceived fear of fall, and quality of life. To begin with the introduction, osteoarthritis is a degenerative joint disease, occurs when the cushioning cartilage between the bones become worn out and the bones starts to rub against each other. This often leads to pain, swelling, restricted range of motion, stiffness, and formation of bony spurs. With advancing age, osteoarthritis of hip and knee is the major disabling disorder due to its restricting effect on mobility, out of which osteoarthritis of knee is most prevalent musculoskeletal complaint we come across. It affects around 30 to 40% of population by the age of 65 years, and it causes the progressive loss of function, displaying increased dependency in walking, stair climbing, and other lower extremity tasks. Thus, osteoarthritis of knee is definitely affecting our mobility. And mobility has a major component, integral component, is balance. Control of balance in all our activities while we are standing, walking, or doing anything is important. And it's dependent upon the sensory inputs from vestibular, visual, and somatosensory systems. There is abundance of literature available on elderly population and also on neurological population, which says that balance impairment results in increased risk of fall and poor mobility measures, and which could ultimately lead to ADL restriction and social isolation. But unfortunately, there's not much of literature available on osteoarthritic population, and whatever studies have been published have used either the force platform or the balance meter as a study tool, which is not that cost effective. So for the present study, we decided to use a cost effective tool, sway meter, for assessing the balance in osteoarthritic population. What the sway meter does, it assesses the postural sway. Postural sway is the indicator of static standing balance, where bodily movements in both anterior-posterior and the transverse directions are analyzed. It is a reliable tool for assessing postural sway. It hardly takes less than 2 minutes to assess a balance with the help of sway meter. This device consists of inflexible rod of 40 centimeters with a vertically mounted pen at its end. The pen records the participant's postural sway on the sheet of graph paper fastened at the top of adjustable height table. It assesses anterior-posterior, transverse, and we can also assess the total postural sway under 4 conditions: on floor, eyes open, eyes closed, and on foam, eyes open, eyes closed. Thus, the objectives of the present study was to study the presence of balance deficits in people of 50 to 70 years with knee OA using a cost-effective sway meter. Also, to study and correlate the disease severity and the fear of fall in people with knee osteoarthritis. Further, to study and correlate previous falls, perceived fear of fall, and the quality of life in knee osteoarthritic population. This was an experimental study as a design in which we took a sample of 60 people aged between 50 to 70 years, and the participants were recruited from the government hospital, Lala Lajpat Rai Hospital, Kanpur. Coming to the inclusion criteria, the age of the participant, as I told, without any biasing of male and female, between 50 to 70 years. The diagnosis of osteoarthritis was confirmed by an orthopedic at the government hospital. Participants with the OA were included if they had pain on most of the days of the previous month, average of more than or equal to 3 on VAS score, and experienced pain and difficulty while getting up from the chair or climbing stairs. To rule out any neurological cognitive deficit which can interfere with our testings, we took a MMSE cutoff score of more than or equal to 24. For the exclusion criteria, if they does not fit our age, they were excluded. Participants who had any neurological or cardiovascular complaint were excluded from the study. If they have consulted the physiotherapist for the treatment of knee joint particularly, they were excluded. Control participants were excluded if they had any signs and symptoms or disability due to osteoarthritic deformity pathology in last 1 year. They were excluded. Control group were also excluded if they reported any deformity, limb pathology, joint effusion, warmth, or less than 125 degree of range of motion at knee joint. They were excluded from the study. Instrument to measure the postural sway, we use the sway meter. To assess the quality of life, we use the arthritis impact measure, short form 2 scale, which was the one of the recent scale used for the measurement of quality of life. For the severity of disease, we use index of severity of knee osteoarthritis, knee. And to assess the perceived fear of fall, we use the fall efficacy scale, FES. The protocol which we used, we took a sample of 60 participants from the Kanpur city, and then they were assessed for inclusion and exclusion. If they fit into the inclusion and exclusion criteria, the consent was obtained, and then the initial assessment regarding the demographics, observation and physical examination for the patient was done. Then the procedure was explained and the instructions were given to the participants. For the assessment of postural sway, the assessment was performed in a bipedal stance with the bare feet, the feet 10 centimeters apart, and under total of 4 conditions. Conditions was randomly presented, and each trial was for 30 seconds. For each condition, there were 3 trials. That comes out to be total of 12 trials per participant. Then the patient was instructed to stand still and without talking, and looking ahead and slightly down at the blank wall of 1.5 meters away. Participants were often seated and rested for at least 1 minute in between the trials. Testing under each condition was performed without no prior practice. This was the setup for the sway meter. If we think that the loss of balance is about to happen, the testing was ceased for that particular trial. For the calculation of sway, the tracing of pen on the graph paper yield the following measurements: anterior-posterior sway, transverse or mediolateral sway, and then the total sway was calculated. A ruler was used to locate outer border of anterior-posterior, and the lateral directions was used to determine the respective maximal sway. Readings were recorded, and for the other variables like quality of life, disease severity, and perceived fear of fall, the rest of the scales were given to the participants to fill up. This is the sample sway which we calculated. The maximum anterior-posterior and the lateral sway was calculated with the help of ruler. Coming to the results, when we compare the basic characteristics of both control group and the osteoarthritic group, we found that on the basis of basic characteristics, both the groups were similar. First, the balance deficits. For the anterior-posterior sway, we did the t-test analysis, and when we found that there was a significant difference between both the groups in all the 4 testing conditions. The graph explains it more better. Under all the 4 testing conditions, the sway for the osteoarthritic group was more than the control group. Similarly, for the transverse sway, there was a significant difference between the osteoarthritic and the control participants. Coming to the total postural sway, the total postural sway was calculated by, can be calculated by simply multiplying the anterior-posterior and the transverse sway, or by counting the total number of square transverse by the pen on the graph paper. There was a significant difference between osteoarthritic and the control group. I would like to explain it further with the help of graph. As we can see, when in the first graph, where the condition was eyes open on floor condition, we can see the control group had a lesser total postural sway as compared to the osteoarthritic group. When we ask the participant to close their eyes, what happens? The visual feedbacks got challenged, and they had to rely only on their proprioceptive feedback. What happens with the osteoarthritic population, that there was a deficit in the proprioceptive feedback, so there was an increased postural sway. Further, when we ask the patient to stand on foam, and in the last condition, when we ask the patient to close the eyes, both the visual and the proprioceptive feedback was deficit in that particular condition, and the sway increased dramatically in the osteoarthritic group. Also, knee pain could contribute in the increased postural sway. What happens? That might be the case. It has to be research should be done on these things to correlate what is the correlation between pain and the balance deficit. But there are few which says that pain around the knee joint can affect the muscles in terms of their effective performance and timely performance. Also, the osteoarthritis is mostly accompanied with the knee flexion contracture, which also contributes to postural deficit and postural sway. The second objective for the study was to correlate the balance deficits and the disease severity. Under all four conditions, there was a significant correlation found between the disease severity and balance deficit, which explains that what happens, and when the balance deficit occurs, there are few physiological changes which are occurring at the joint. These physiological changes leaves the joint vulnerable to loading and shearing forces, and this accelerates the joint degradation and causes the increased severity of disease. Next, as explained with the elderly population studies, that previous number of falls could affect the person's fear of fall. This was also significant with our, this was also confirmed with our study results, that there is a highly significant and strong correlation between last fear of number of falls and the fear of fall. What happens if the person falls? There is a tendency of people that to restrict themselves from activities. So there is a needless restriction towards the activity. They tend to restrict themselves while doing any physical activity or social activity. They do not participate, and eventually what happens, they confine themselves in their home, or they just ignore all the things in life. So this is confirmed with our study, and also this social isolation could lead to decreased quality of life. This was also though the correlation value is not that great, but it is significant at p-value of 0.01. Coming to discussion, the key finding of the present study is that the people with osteoarthritis has significant balance deficit as compared to the control group. The amount of anterior-posterior transfer and total sway suggests that the osteoarthritis significantly increased sway displacement as compared to people who had no symptoms of osteoarthritis. The results of the study agree with the Herman's findings, which showed that osteoarthritic population had significant balance deficit in both anterior-posterior and transverse direction under eyes open and eyes closed. Findings of the Radzwalf also suggest that the injury or any pathology around knee have definite neuromuscular impairments such as decreased quadriceps strength, poor lower limb positioning and proprioceptive deficit, and impaired postural control. The magnitude of postural sway is the amount of movement of center of pressure. Literature suggests that when the center of pressure displacement falls outside the limits of stability, the person gets fall. Hence, greater the postural sway, more will be the chance of person to lose their balance. Balance deficits could lead to fall. Hence, we studied how the previous fall affect the person's ability to carry out day-to-day activities. We found that previous falls have significant impact on person's fear of fall. Excessive fear can lead to needless restriction in participation of physical and social activities, resulting in physical deconditioning like muscle atrophy, decrease muscle power, etc., social isolation, depression and distress. The result of the study confirmed that previous episodes of fall strongly correlate with person's fear of fall, activity restriction, associated physical deconditioning and social isolation can in turn affect the quality of life. I can sum up the discussion with this vicious cycle which get created in the osteoarthritic population. What happens in the osteoarthritic people, there is a balance deficit leads to a loss of balance or episode or event of fall. Even repeated events of fall or leads to fear of fall leads to activity restriction ultimately leads to physical deconditioning leads to depression, distress, social isolation, and this creates a vicious cycle which ultimately affects the person overall health and quality. And these kind of disorders which we cannot stop osteoarthritis. It happens as a natural aging process, so we need to consider, we just do not need to just focus on patient pain. We have to consider the patient as a whole as such. Future studies are recommended to study the gender-based difference and also to establish a relationship between balance deficit, muscle strength, pain and disability in osteoarthritic population. Also, it is recommended to calculate the amount of dynamic balance deficit in osteoarthritic population. Conclusion: the finding of the present study suggests that people with osteoarthritis present with increased postural sway and hence significant balance deficits are there. In clinical terms, the result of the present study could be concluded as, while attending any person with osteoarthritis, it is important just not to treat pain and the X-ray findings, but to treat the person as a whole. We should also consider their balance deficits, their fear towards fall, their previous number of falls, and what is the quality of life we should assess at the first sitting itself, so that we can measure the impact of healthcare what we are giving to our patients. Thank you.